So let's move on to the next talk, and we're very fortunate to have Dr. Lea Velsher with us today. She's going to talk about the new kid on the block, as she put it, and this is the Non-Invasive Prenatal Test, or NIPT. I'm sure you've heard about it. I'm sure your patients may be asking you about it, so it's important for all of us to know about it. So Dr. Velsher studied medicine at McGill and trained in pediatrics at Montreal General Hospital, and then did her fellowship in genetics at Sick Kids in Toronto. She's a fellow of the College of Medical Geneticists. She's a consultant at the genetic program at North York, where she provides full genetic services from zygote to the elderly. I like that. She is the advisor for the genetic clinic at Rouge Valley, which we started in 1992, and it's one of our main clinics. And one of her areas of interest is prenatal diagnosis. Dr. Velsher is also a lecturer at the University of Toronto and is committed to teaching genetics to healthcare providers. Dr. Velsher.
Thanks for inviting me, and to the organizers. I always am happy when genetics gets included in some general CME, because genetics is everywhere, even though people don't think about it. I don't have as dramatic a presentation as Dana did, because I don't have that great video, but what I wanted to do in 30 minutes was tell you about NIPT, and I really tried to make it as practical for us as possible. The idea is, what does this mean for you in your practice, and what does it mean for your patients, and if they want it, how do you go about getting it, and what do you do with the result? And I'm supposed to figure out how this clicker works. There we go. I have no biases or financial disclosures. I'm just here to talk. So the NIPT is a screen for primarily for Down syndrome. Primarily for Down syndrome. And so I wanted to put some things in perspective, because the baseline risk when a woman is pregnant, she has a 2 to 3% chance to have a baby born with a medical problem. If you take the general population, all pregnant women together, the overall risk for a baby born with Down syndrome is about 1 in 700. And I just wanted to put that into perspective, because there is a huge industry and a huge medical ministry infrastructure that's geared towards Down syndrome. But in the process, it does also pick up a lot of these other birth defects. And the idea behind prenatal diagnosis in Ontario is to give information to couples and give them options and support them in their options. And for some, they will end pregnancies. For others, they will continue pregnancies, and we're able to give them a proper sort of a management plan and an immediate postnatal plan that could dramatically improve the outcome for the newborn. So that's the idea behind all of this testing. For quite a number of years, we've had the first thing we had as a way of screening for Down syndrome was maternal age. It is a terrible screen. Okay, it detects 20% of cases of Down syndrome. Most of you would not even consider a screen that gives you a 20% detection rate. So it is not the best screen, but it's the one that's ingrained in everybody, including most of our patients. Since then, we have prenatal screening as integrated prenatal screen, or the second trimester screen, or first trimester screen. All of those are basically using biochemical markers from the pregnancy to try to give us an idea of what's the likelihood for Down syndrome. And some of them, like the IPS in the second trimester, give us information about spina bifida. And we've added the nuchal translucency ultrasound at 12 weeks, measuring the back of the baby's neck. Gives us some information about Down syndrome, other chromosome anomalies, possible cardiac defects, and so on. So a bigger NT is a clue for us that there's a problem. And the amniocentesis, or chorionic villus sampling, stay options for patients, but they're not there for every pregnant woman. So a 25-year-old who comes in and says, you know, my cousin in the States is 25 and she just had an amnio and I want one, without some other risk factor, she's not getting one. So, and then in February of 2012, I think it was, we started being able to provide non-invasive prenatal testing, which is a misnomer. It should be called non-invasive prenatal screening. It is not a diagnostic test, and with all due respect to the representatives from the companies, it does not replace an amniocentesis in the information that it gives. So sometimes it'll be thought of by the patients as good as an amnio. That's not quite true, but it can replace the amnio for women who really don't want to do an invasive test if they're willing to accept the fact that it is a screen. And there are, in Ontario, 3 companies that are selling this product. There are many more. There's another one called Sequinome, and there's a bunch of others that are out there. But the 3 that may come knocking at your door will be the Natera company, which sells a panorama screen, Ariosa company that sells a Harmony screen, and there's another one called Veronata that sells a Verify screen. That doesn't yet have a good distribution network, so they may not come to you. They all have not slightly, but different ways of doing their technology, and they all have arguments among themselves over who's got the best system. I have to say that from a general practice point of view, including general genetics, it's not something that you have to, I didn't want to spend the time going on into the different techniques, but I'm happy to talk during the break if anybody has questions. Because the technologies are a little bit different, they may perform a little bit differently, but actually in all my reading of the data, they're pretty equivalent. So how do you choose a test? We'll talk about in a minute. NIPT works on the basis that there is DNA, pieces of chromosomes, that come from the placenta that float in mother's bloodstream free of cells. So it's called cell-free DNA. And in fact, we all have cell-free DNA floating in our bloodstreams. Cells that have broken up, blood cells or whatever, the cells have broken, the chromosome pieces float around in our blood. So the majority of cell-free DNA in a mother's bloodstream is hers. But somewhere between 4 and 10%, and maybe even more at the end of the pregnancy, comes from the baby, but specifically from the placenta. And the placenta can sometimes have some abnormalities that are limited to the placenta and not present in the baby. So that's just a point to make, that it's not directly testing the fetus, but it is testing fetal DNA that comes from the placenta. And what we can do is, I don't know if you can see that, but there's the idea that there's mother's cell-free DNA and then there's babies, and the technology today allows us to take a blood sample from mom, I think it's 2 test tubes, maybe like 20 cc's, maybe less, send it to a specialized lab, they extract all of the DNA, and then they use various different methods to see how much is coming from the baby versus how much is coming from the mother. And we know what to expect, because there should be 2 of every chromosome in mom and 2 of every chromosome in baby. And if baby has an extra number 21 chromosome, there'll be more number 21 pieces that are there. And Panorama is, I believe, able to tell the difference between maternal and fetal DNA. The other methods using sequencing don't actually distinguish between mom and baby DNA. They just count the pieces. And so that picture is not quite correct, because you see how the baby DNA is white and the mommy's DNA is green. That's not true. It just all looks the same. So in most of the other sequencing kinds of companies, so the different technique means that they're not able to always tell the difference between mommy and baby. But it's really just a comparison thing. We're saying, is there more of number 21 or number 18 chromosome pieces there than we're expecting? By the way, my slides are already a bit out of date. So here I said that they all cost around $800. It's about that, but it varies a little bit, and it varies if the ministry's paying and which company it is, and I think the price may even be going down a little bit. Some of the companies, Harmony is actually the company that's used a lot at North York General, because they've set up a collecting site in our hospital. So our patients can come in, if they want to do NIPT, they just go up to our lab. So it's very convenient for them. Other people who don't want to go up, who don't want to be doing the blood test that day, if they're in some other place, they want to go to whichever lab. Life Labs will do Natera. And so we have patients doing either. The Verify, as I said, doesn't have a good distribution system, so Mount Sinai uses Verify for a number of reasons, and there's another clinic that does. But so it's convenience for us, convenience for the patient, and the turnaround time can vary, and really it's customer service. So I have to say, although I have a lot of information about how good is the screen and comparing detection rates and stuff and how the test is done, it really comes down to what works best for you and your patients. And in this neighborhood, I would say that Panorama is leading the charge in terms of being able to provide service for us. And that's not because they're sponsoring today. It's just, so in our clinic at Rouge Valley, we actually use Panorama a lot. So what does NIPT tell us? Does it tell us that a baby absolutely is normal and perfect? Anybody think they could do that with an NIPT?
No.
It can give us the likelihood that the baby has Down syndrome or trisomy 18 or trisomy 13. And guys, you got to listen because there's a quiz at the end. Okay, just so you know, there is really a quiz at the end. It also actually screens for Turner syndrome. So IPS, or first trimester screening, actually are designed to look for Down syndrome, and it also can pick up trisomy 18, but those typical biochemical screens are not really designed to pick up Turner syndrome or trisomy 13. It can also tell us if the baby's a boy or a girl, and you can do an NIPT test as early as 10 weeks gestation. So it's very helpful for geneticists. If I have a lady who comes in and says, I am a carrier of the X-linked Duchenne muscular dystrophy with a chance to have an affected boy, but my daughters will not be affected, what we have done up until now is we would say, come on in, we'll do a chorionic villus sample or an amniocentesis with a small miscarriage risk. We'll tell you if it's a boy or a girl. If it's a girl, we stop right there, and if it's a boy, we'll test for the disease. So the woman, 50% of the pregnancies will be female, and she'll have done an invasive test for essentially no reason. Now we say, come on in, we'll do your test for NIPT, your NIPT test, and the ministry will pay for it. We'll tell you based on that whether it's a boy or a girl, and if it's a girl, then you don't need to do an amnio. And so we save 50% of invasive tests, and we may save a small percentage of pregnancies that would be lost. So it's very useful for us for screening in terms of fetal gender. It does raise the ethical question of a woman who can get NIPT, and there is actually a company, a private company, that will do gender by NIPT for $200 that one of our patients told us about, because it's not part of our service, obviously. And so people can choose the sex of their baby, and that is an ethical discussion for another day. And it's actually quite a complex discussion. It evokes a lot of response, but for us, from a medical point of view, it's very helpful. Veronata and Panorama, Natera, are now offering to also test for rare chromosome deletions. They're called microdeletion syndromes or disorders, and there is a booth for Panorama, and they've got some information on that. This is not the standard. It's not what we usually talk about to people when we're offering NIPT in the genetics clinic, but any woman who wants to can pay the extra, I'm not even sure what it is, a couple $100, $300, something like that, and actually test for a few rare chromosome disorders. And when you put all the rare disorders together, it's something that happens one in a few thousand pregnancies, and they are serious chromosome disorders. If the woman has paid for microdeletion testing with NIPT and the report comes back saying this baby has a deletion of 22q, the next step is an amnio. If a woman does NIPT and it comes back saying there's a high risk for Down syndrome, the next step would be to offer her an amnio. And we do have a patient who had a 96% risk on Panorama for Down syndrome, and her amnio is normal. So there are false negatives and false positives. So we also have a case of a trisomy 18 that was missed on NIPT. It was picked up because the ultrasound was abnormal, so we did an amnio looking for problems and found trisomy 18. So there, you have to remember, this is a screen, and it will miss some cases, and it will scare some people for nothing. The microdeletions are not that common, and the data is very, very new. I haven't been able to get my hands on the raw data yet, but it is something that's out there. And in fact, the NIPT has been used for other things because, for example, if you have an Rh negative mother, it means that she does not have genes for the Rh positive D protein. If her husband is Rh positive, he's got a gene for this protein. If you test her blood and you find DNA pieces for D positive, Rh positive blood, it's telling you the fetus is Rh positive. So now you know you have Rh positive mom, Rh negative mom, Rh positive baby. You know you got to do the ROGAM and stuff. So in Britain, they've been using this for a number of years as a way to decide who should be followed for Rh disease. And if you could do it for Rh disease, you could theoretically do it for other paternally inherited dominant diseases, Huntington disease, whatever. We are not yet doing these things, but this is the move. And I'm telling you, I just got an email yesterday, so I didn't change my slides because I haven't read the paper yet, about Panorama and twins, because the question was, can you use it if you have a twin pregnancy? And the answer now, I think, is yes. But I haven't looked at the data. So things are changing. I get 30 minutes to talk about something we talk about for hours every day in our clinic. It doesn't necessarily tell you if the baby has other problems, birth defects, triploidy. It doesn't tell you about other chromosome problems. So if there's a baby who has some weird deletion or some strange translocation or something, the NIPT isn't going to signal that. So it doesn't tell you everything about the baby, and it is not a diagnostic test. But we do have some women who want to do NIPT, and we tell them it's not diagnostic, and they're comfortable with that. They go, that's enough information. A 99% accuracy for me is good enough. I accept the fact that there's some difficulty. Sometimes the test doesn't work. We call it a no-call rate. It's listed in the literature as 5%. In our clinic, it's been less than that. That means that the woman gets her blood sent and she doesn't get an answer. And a company will offer sometimes to redraw and do it for free, and if they still don't get an answer, they will refund the money if the patient has paid for herself, or to the ministry, I guess. They just don't charge the ministry. If the woman is very fat, it can be a problem, and the reason for that is the whole idea of what's called fetal fraction. Remember the picture with the green and the white? If you are testing the DNA and you really want to make sure that you're capturing the baby's chromosome pieces, you want to make sure there's enough of the fetal DNA in the sample. In other words, the fraction that's fetally derived has to be sufficient. And when the woman is very heavy, her fetal fraction tends to be low. At least that's our theory. So we sometimes will not be able to get a call, or will not be able to give an accurate result. But I haven't been able to figure out what very fat is. Like, I don't know what BMI that means. And we have certainly had heavy women who've done an okay NIPT. My slide says it's not yet validated. All of the original studies were done on women 35 and older because they were all eligible for amnio in whatever jurisdiction. So 35 and older is the age that it's being validated for. But there are a lot of studies out there already looking at the younger women. The difference is something we call positive predictive value. And think about it. Think about having a bowl of red jelly beans, and there's one black one. And you close your eyes and you pick out a jelly bean, and someone says, do you think it's going to be black or red? You're probably going to be picking up a red one because there's only one black one. Now you have another bowl of jelly beans full of red, but there are 50 black ones. The chance that when you pick one up, it's going to be accurately black, if that's what you're looking for, is higher. I'm assuming your eyes are closed. So if you take a low-risk population and you have a screen, the chance when you get a positive result, there's a higher chance that that's a false positive. Because to start off with, you don't have that many black jelly beans in your bowl. So if I can do that, I can show you the math. But so the question is, are we going to be having a little bit higher of a false positive rate if you have a very low risk population. And it's relatively expensive from a public health point of view. So the government funds IPS and FTS, and they've looked at this. They can't afford to do NIPT for everybody yet, even though it's actually a better screen. The detection rate for Down syndrome from IPS is, let's say, 85%. So out of 100 Down syndrome babies, IPS will miss 15. The detection rate for NIPT is about 99%, so we'll miss 1. The false positive rate for IPS is about 3%, and for the FTS about 5%. So 1 out of 20 women will get that phone call, come to my office, there's a positive screen. But the false positive rate on NIPT is about 1 in 500, something like that. So you actually have a much better screen. Unfortunately, it's more expensive, and the government can't afford to offer it to everybody. But I think it's the way things are going to go. And right now, the turnaround time for Panorama, I think, is about 10 days. For Harmony, it's about 10 to 12 days. Veronata is 5 days. So that's a bit of a problem. I want to go through, one of the issues is consanguinity, and the Panorama reps there, because the way that it's done, if there's strong consanguinity, you might not get as good an answer from Panorama, so that's when we use Harmony. But as I said, it's got a very high detection rate for Down syndrome with a very low false positive rate. It screens for trisomy 13, it screens for Turner syndrome, and you can do it anywhere in the pregnancy. So we have women who may come later in the pregnancy with an abnormal ultrasound or some concern. They don't want to do an amnio, they're continuing their pregnancy anyway, but they just want to know. And we could do NIPT at 25 or 30 weeks. And if it's positive for Down syndrome, at that point we might say, that's what we think is going on. It's still just a screen, but let's prepare. And so it's very valuable. And if the woman's a smoker or diabetic or whatever, it doesn't seem to matter. The ministry will pay for NIPT. And again, I ask you to stop at the Panorama desk because he has the front sheet, which is what GPs can order for NIPT. So you can order NIPT on any of your patients and the government will pay, except you have to get the woman to fill out a prior approval application form for full payment. And these are the indications that a GP can order NIPT for. And then there are other indications, so if there's anything like a positive screen or it's twins or there's an abnormal ultrasound, they should come to genetics. And we have a genetics clinic at Rouge Valley, and we're happy to talk to people about it because we can order it under additional circumstances. That's what the form looks like a little bit, but the form is at the Panorama desk. You can also get the form by Googling Ministry of Health, Ontario, prior approval application form, and it'll come up, and that way, because the Panorama forms are pre-populated with the Panorama address, but you actually have to send that off, and then you get a letter saying, yes, it's okay, we'll pay for it, and then the patient draws her blood. So there's this bureaucratic process, which I'm hoping will go away. And that's what, this is actually a Harmony result, my apologies, but we do a lot of Harmony, and I'm trying to show you that the result, the report you get back isn't always that easy to read, but it should be. Well, if you look at it enough, this is a positive screen where it says trisomy 21 high risk with a greater than 99% chance, go to genetics. For trisomy 18 and 13, it says low risk. And then they try to do it on a scale kind of thing to visually show. And then the other labs produce reports that look different, but not that different. And so you have to read through it to kind of see, well, what did the result actually say? And I did have a doctor send me something like this and say, the result is positive for trisomy 21, 18, and 13, because he hadn't really read, and it has all those things in there. So the other problem is, we've always defined advanced maternal age for amnio as 35, and at North York General and I think Mount Sinai, they're still doing that. The Society of Obstetrics and Gynecology of Canada say it's 40, not 35. So the Ministry of Health will pay for any 40-year-old woman who wants to do an NIPT, regardless. But if she's 35 and she wants an NIPT, she has to pay for it herself. So we get into these dilemmas of sort of inequity and why do you have to get, you can go get a free screen, a free test, which is invasive, or the other test costs money. And actually, I'm going to skip through these. You're just going to have to look it up. Unfortunately, they're, of course, because I wanted to actually do I really meant there is a quiz. Okay. Oh, and that's just to remember, there are never 100% guarantees, right? A baby can be born with a problem. If we do an amnio and we tell you the baby doesn't have Down syndrome, the baby will not have Down syndrome. But will the baby be perfect? Okay. If you guys have a piece of paper in your bags, you do, because I need you to make a note of, these are your, it's this multiple choice thing. I wanted to give you just a few scenarios for 5 minutes. We're starting 2 minutes late. And you have a choice. You could say to a woman, you can offer self-pay NIPT, and then you just give her a requisition and she goes and gets her blood done. Or Ministry of Health and Long-Term Care will cover it. Or you could offer a prenatal screen biochemistry type, which is covered by OHIP. Or tell her maybe she wants to do an amnio or a CVS. And there is always the option for pregnant women to do nothing. Okay, they are not obliged to do any of these things. So what I wanted to do is give you a few scenarios. Okay, so A is self-pay, B is NIPT covered, C is IPS, D is amnio, and E is nothing. Healthy 40-year-old woman. Okay, she's at 8 weeks pregnant. She comes to your office. You can choose more than one. It's not a single answer. And I just for the first 5, I just want you to write down your letters, like your choices, and then we'll go to them. Okay. So for a 40-year-old woman, what are the different things you might offer her? If the woman's 28, what might you offer her? They're both 8 weeks pregnant. If she's 35 and 8 weeks pregnant, so these are just normal pregnancies. They just come to your office and they say, I hear there's some screen or whatever, and actually you're supposed to offer things or discuss them with your patients. 25-year-old woman who comes in, her IPS, her integrated prenatal screen risk for Down syndrome is 1 in 250. What can you offer her? And a 25-year-old woman whose first trimester screen is 1 in 250. What of all this list could you offer her? Okay? Can I go to the answer part?
Anyway.
So give you another 30 seconds or less. Okay. This is what's going to walk into your office.
Yeah.
Okay. 40-year-old woman, I said, I should actually, well, I'm going to go back a second. So the one thing is she's 40, she can go and do an amnio. And if actually she's 8 weeks pregnant, she could do a CVS, which is only available between 11 and 14 weeks, 13 weeks and 6 days. So that is actually something that would be offered to her. She could do NIPT by Ministry of Health. And I actually have some women who walk in and they want to do everything. They want the IPS, they want the NIPT, and they're going to do an amnio. And really, that's a gross misuse of health resource dollars, because if she's doing an amnio, she doesn't need to do the other screens because their purpose is to tell her whether it's worthwhile doing an amnio. She's going to do an amnio anyway, so she doesn't need these other screens. Okay. The other...
Shouldn't E be up there too?
Yes, sorry, I apologize. E should be on every single... E should be an answer for everything. Okay. Okay, what was my next one? Was a 28
years old.
Yeah, okay. So what did you guys want to do for her?
28 years old.
A.
Okay.
Okay, so A is an option. B is not an option. If she's just 28 and no other risk factors, the ministry will not pay for her test. C is actually the standard of care, is to offer her IPS or first trimester screen, or second trimester if she comes in too late. So the standard of care is still to offer all pregnant women the option of OHIP covered IPS, and if her, or FTS, and if her screen is positive, then she would be eligible for something else. We wouldn't offer her amnio, and of course she could choose to do nothing. So C, and the one thing is she's 28 and she wants to do an IPT, she can pay for it, and she can do it.
Yeah.
35-year-old. The interesting thing that's different with the 35-year-old is, again, standard of care would be to offer her IPS, FTS, or second trimester, but she could actually get an amnio, for example, at North York, because we're still offering amnio. And of course, she could pay for NIPT instead. Okay. What was my next one?
The gravidity counts, like this at
No,
G-
no, I just put it in there because she's pregnant.
No,
But,
yeah.
gravidity doesn't count. Down syndrome, for example, happens at any
Yeah,
age in any pregnancy, so all of this information is irrelevant.
Mm.
20, whatever, 1-year-old woman, young woman with a positive IPS, 1 in 250. Does she qualify for MOH and IPT? NIPT covered by ministry?
Yes. 35?
No.
No,
The
35.
positive,
40.
okay, she's a young woman, but she has a screen of 1 in 250 risk, but the positive cutoff for IPS is 1 in 200.
Yeah.
So she has a negative screen,
Yeah.
and therefore she doesn't qualify for Ministry of Health covered NIPT.
Yeah.
She does qualify for amnio if she's old enough, but not if she's younger than 35. So really what's left to like a 28-year-old with a 1 in 250, if she's anxious, would be an IPT. And the other case was the other woman who has a first trimester screen of 1 in 250. The cutoff for first trimester screen is 1 in 350. In other words, any risk by first trimester screen of 1 in 350 or less is considered a positive screen. So case number 4 has a negative screen, and case number 5 has a positive screen. And the reason is the detection rate is better with Down syndrome. So the chance, like if I give you a 1 in 250 risk on an IPS, which is a negative screen, I'm more likely to be right that it's negative than I am to be right with first trimester, because first trimester has a lower detection rate. So I think I'm out of time. I have another case scenarios. I just wanted to add one last thing. If there is an actual abnormality or a family history of a medical genetic problem, or you're not sure, please call us and or refer the patient to us. We're happy to answer your questions if you're not sure. We're happy to help sort out the NIPT, and we're happy to see any of your patients. And we have a booth with our information sheets and referral information and stuff right next to the table where you signed in. So please come and visit us there.